Okay. So this is my agenda. So I will start saying that this is a conceptual model of heart failure, and this very old conceptual model of heart failure, and this conceptual model of heart failure was based on hospitalization, or in other words, of need of hospital admission. And we know very well heart failure, acute heart failure, it's a progressive disease, it's a multi-event disease, and need of hospital admission was stipulated in the previous edition of heart failure guidelines in 2012 and 2016. And I underlined urgent need to hospital admission. But what we learned in the last years, we learned from two clinical trials, Paradigm HF and MED-CRT, and in these trials, other events related to heart failure, like outpatient visit for worsening signs and symptoms requiring intensification of therapy, or just emergency department presentation, staying less than 24 hours and receiving IV furosemide for worsening congestion, were associated with higher risk to die. And this is an important signal for medical community, and this signal was specifically investigated in biostat-CHF. And in biostat-CHF, some patients, ambulatory patients with high risk criteria, had a risk to die at 1 year, similar with acute heart failure patients requiring hospital admission. So this concept has been integrated in new conceptual figure of acute heart failure, and heart failure is again a multi-event disease, but setting of care is not a biological threshold, and patients presenting with acute heart failure may have a similar risk to die irrespective of presentation in emergency department, leading to hospitalization or not, or just in outpatient clinic for worsening signs and symptoms. That's why current heart failure guidelines mention clearly unplanned, because acute heart failure, it's an unplanned event, unplanned hospital admission or emergency department visit. In terms of diagnosis, for 2021, current AAC guidelines, diagnosis is similar to universal definition of acute heart failure. And being a syndrome, we are starting with pre-test probability, with Bayesian theory saying that we have some kind of pre-diagnosis in terms of signs and symptoms. And we need additional tests when available. Natriuretic peptides we may use, especially, particularly to exclude acute heart failure patients due to very high negative predictive value. And some imaging tests like chest X-ray, focus echo, echocardiography, and for sure ACG. So again, depending on our availability, we can use natriuretic peptides, which is an excellent tool, particularly to exclude heart failure. And also they have a positive predictive value, but other cutoffs should be used to demonstrate positive predictive value. When natriuretic peptides are in gray zone, we need additional tests like focus chest X-ray or comprehensive echocardiography. In terms of classification, and I will try to go very fast to gain some time for the next speakers. Any classification should consider pathophysiology, prognostic, disposition, decision, and for sure, management. And at the end of the day, a good classification should inform about epidemiology, should have some insights in the future research study, and provide data about economics. And in 2021, we have 4 classifications. First, it's de novo versus worsening chronic heart failure. Second, it's congestion hyperperfusion. The third, it's clinical profile. And the last, it's CHAMPIT classification. And the current edition of the guidelines, it's using all these classifications. First of all, because of prognostic information, and we know from Italian study 10 years ago, from Danish study, that patients admitted for worsening chronic heart failure, so with worsening symptoms, but with previous history of heart failure, had a worse prognosis than patients with de novo heart failure. This is very important considering progression of heart failure. And progression of heart failure should be considered in relation with guideline-directed medical therapies. So this is not equal, is to distinguish worsening status in a patient already on guideline-directed medical therapy or in a patient with history of heart failure but without guideline-directed medical therapy, because at the end of the day, we should prevent the death or progression to advanced heart failure. In terms of other classification used for patients with acute heart failure, congestion hyperperfusion classification remains a very good classification. It's a decisional classification. We may initiate IV vasoactive therapy based on this type of classification. And I should remember several studies saying that regardless of clinical presentation and classification of admission, what is important is classification of discharge. Because congestion of discharge is associated to worse prognosis in terms of mortality and readmission, and these are data coming from clinical trials and the registry. One of the major limitations of this classification, congestion hyperperfusion classification, this type of classification is not able to distinguish pathophysiology of congestion between right and left sided congestion, let's say, in other words, between fluid redistribution or overall fluid overload. That's why the main classification used in 2021 was clinical profile classification, like 20 years ago, proposed by Professor Mihai Gheorghiade in acute heart failure syndromes. And actually, we have acute decompensated heart failure, cardiogenic shock, acute pulmonary edema, and acute right failure. Although with clinical characteristic overlappings among clinical profile, this type of classification succeed to provide important insights for therapeutic management lines and also for disposition decision. And at the end of the day, irrespective of classification, we should not forget that clinical severity of patients with heart failure, it's determined by complex relationship between cardiovascular substrate, comorbidities, and the precipitants. And this is the reason why 2021 guidelines took over the previous scheme about CHAMP, C from coronary, H from hypertension, A from arrhythmia, M from mechanical, and add I and T, I from infections and T from tamponade, because this type of life-threatening presentation should be excluded or should be treated before any congestion hyperperfusion algorithm. So in other words, you cannot start giving IV furosemide to a patient with cardiac tamponade, or you cannot start giving IV furosemide to a patient with ventricular septal rupture in spite of severity of congestion. For management, this is very nice because the guidelines say again and again, diagnosis and management should go and evolve in parallel. And again about phenotyping, because we have some kind of phenotyping of management based on clinical profile, so different management in acute decompensated, in right acute heart failure, in pulmonary edema, in cardiogenic shock. But what is nice, we have an additional very important concept. And if you read among the rows, we have initial therapy and escalation therapy. Why we need this concept? Because in hospital trajectories. So in spite of IV therapies, some patients, let's say 20–25% of patients presenting with acute heart failure are getting worse. What does it mean getting worse? Initially improving and then worsening, typical profile from relaxed studies. Some patients are deteriorating or have a negative evolution, and some patients are dying the first 24 hours of admission. So it's very important. That's why we need escalation therapy. That's why we need initial therapy to stabilize the patients, to assess and reassess clinical evolution of the patient, to introduce this concept of escalation therapy. And if you read the guidance for patients with cardiogenic shock, also for patients with acute pulmonary edema, escalation therapy in terms of mechanical circulatory support means to initiate early since presentation for patients with hypoperfusion and to add a second type or combine left and right mechanical circulatory support in case of worsening course. So let's say this is our proposal, and you'll see it very soon in the manuscript about how to classify patients with acute heart failure. Seems to be very granular, but this classification answers to many clinical needs. And this is the decisional tree of patients with acute heart failure, presenting with acute heart failure. And we have 3 levels how to stratify the risk at initial triage, during hospitalization, at discharge. There are very few studies stratifying patients in ICU. And the philosophy, you should collect simply variable to decide which group of patients should admit directly in ICU. There are, again, very few studies, but selected patient based on ejection fraction, hyposodemia, and low systolic blood pressure at admission could be important. And this is the reason why current guidelines introduce this table. And please read this table, because provide level of care by intensity of care in critically ill patients presenting with signs and symptoms of acute heart failure. Not only high risk, but low risk. How to exclude patients who may be discharged in the first 24 hours or discharged directly from emergency department to home. We have some risk score criteria, Macy's, Spanish risk score, and Canadian risk score, saying that at 30 days, if we are following this score, we have 0 mortality. This is important. But most important reason for readmission in the United States, in my country, also in your time, problem, are social problems. Are patients with self-social support, living alone in the houses, not only quality of medicine. So only scoring is not enough to predict readmissions during the 30 days after discharge. For post-discharge mortality, we have several scores, several variables collected at admission and systolic blood pressure at admission, but not only at admission. Also, variation during hospitalization and at discharge, it's related to mortality. We should understand exactly the value of renal function, which is valid in the context of congestion, otherwise it's not so important. And also think about residual congestion at discharge in all registry and clinical trials. And this is my final scheme, how to use definition, classification, re-stratification in patients with acute heart failure, because acute heart failure is a syndrome. It's like fever, and what Professor Georgiades said, this is a time for a new definition. Thank you so much.
Excellent. Thank you very much.